Well, thank you so much, Stephanie, and welcome you all to this webinar. This is Manuel Sanchez Luna from Madrid, Spain, and I want to thank you for joining us to this webinar session from Draeger, where we are going to talk about high-frequency oscillatory ventilation in the neonate, which is the main goal of this lecture. Well, I will try to do my best to focus in a very practical way on when and how do we use this mode of ventilation. But before going there, I would like to spend a few minutes talking about how does it works and some of the principles for using the high frequency oscillatory ventilation. You all know that this mode of ventilation is not a very physiological way of breathing. So I would like to focus in the two main components of this mode of ventilation. One is the continuous standing pressure that is generated from the ventilator and is going to be transmitted into the lung. Then the lung is going to be inflated. All the alveolus, most of them, is going to be recruited, and we are going to improve oxygenation. And the other one is some kind of mechanism that we are going to use to try to wash out CO2 and move all the gas from the lungs of the baby or patient who is connected to the ventilator. So let us take a look at this very easy and scheme of a ventilator with a high frequency oscillatory ventilation. We have some kind of tubing. From this tubing we have a continuous flow that is going to generate mean airway pressure. This pressure is going to be transmitted into the lungs, and then the lungs are going to be inflated when we overcome the opening pressure of the alveolus. Well, in this tubing system, we have in an air chamber, and an air chamber where there is some area that is going to move forward and back by a piston or membrane or a valve with a force, what is called delta P, that is going to compress the gas in this chamber, and this gas compress is going to transmit energy, and this energy is going to be transmitted into the lungs as a very small airway pressures. This small airway pressure is going to be generated at a very fast rate, and this transmission of energy is going to contribute to the gas exchange into the lungs. So when we have this kind of displacement, then the lung is going to be inflated by recruitment of all of the alveolus due to the mean airway pressure, and then the displacement, the very fast displacement of this membrane, piston or valve is going to be transmitted into the lungs where the gas exchange is going to be induced. So the two main components of the high frequency oscillatory ventilation are the continuous distending pressure to open the lung, and by this we can increase oxygenation, and the other one is the energy created by the oscillation of waves that is going to improve mostly the ventilation. You can see here some of the waves. This is the flow up and down at a very fast rate and the pressure generated by this displacement of the waves. So comparing with the conventional mechanical ventilation waveform of the pressure, you can see this is a regular normal wave of the pressure. For a conventional mechanical ventilation, the pressure goes up until peak expiratory pressure and then goes back again to the end expiratory pressure. This increase in the pressure is going to generate tidal volume movement into the lungs, and this tidal volume is going to reach the alveolus. Then you are going to have this exchange in the gas into the lungs. With the high frequency oscillatory ventilation, you can see how we have a mean airway pressure continuously maintained into the lungs, and this increase and decrease at a very fast rate of small delta P pressure that is not going to generate, as we know, the tidal volume as in conventional mechanical ventilation, but it's going to generate a very small tidal volumes. From now, we're going to talk about high frequency tidal volumes. These high frequency tidal volumes are not going to reach the alveolus, but are going to transmit energy into the lung and are going to contribute to the gas exchange. So let us see some cartoons of how this works into a lung where most of the alveolus are closed because we have to increase the pressure until we reach the mineral pressure that is higher than the opening pressure of the alveolus. So you can see here how as we increase step by step the mineral pressure of the ventilator, we are going to open the lung. And opening the lung, because the lung is mostly inhomogeneous, we are going to open as we reach the opening pressure of different alveolus areas, and then finally we can recruit all the alveolus of the lung. But let us go to the animal lab to show you how this works in real life using a rat, a lung from the rat, but a lung without any gas in. But this is a normal lung with surfactant in. So when we connect this small lung without gas in to a mineral pressure of 0, and we increase into to 4 and then to 10, you can see how we have no appearance of gas in this lung. But a certain pressure in here is 20. You can see how some of the areas of the lung are beginning to be open. This is because in these areas we reaches what we call the opening pressure of these alveolus. But you can see that some other areas are still empty of gas. So we increase them to 30, and now you can see how most of the lung is completely open, but some areas are still closed without any gas in. So probably in these areas what we have is a higher opening pressure to apply. So we go to 35, and then you can see how nicely all of the lung is completely open. So what can be occur if we go down to 30, 20, and 10 back? Okay, I want to remember you that this lung is a lung with surfactant, just empty of gas, but with surfactant. So because we open the alveolus due to the presence of the surfactant, when we decrease the pressure, all the alveolus remain open. And if we go down to 20 or even 10, or then 4 or even 0, there is still some gas into the lung. So this is the most important thing to remember. So we open the alveolus, and then we can reduce the pressure until we find what we call the closing pressure of the alveolus. If we represent this relationship of volume and pressure, we can construct this typical loop of the inspiration and expiration of the pulmonary physiology. And this is the most important approach that we have to remember when we are using high frequency oscillatory ventilation, is that what we want is to keep the lung inflated all the time. And we need to prevent overdistension when we apply pressure, but also we need to prevent atelectasia when we try to decrease the pressure. This is what we call the opening lung strategy. So let us go again to the animal lab, and now let me show you how occurs when we apply pressure during conventional mechanical ventilation to another lung of a rat, but now a very distressed lung. This is a lung without surfactant, and you can see how when we apply pressure in the way of conventional mechanical ventilation, what we have is overdistension, and the lung is increasing and decreasing the volume during conventional ventilation. So we can do this with or without high frequency ventilation, but there are some differences that we are going to talk about that. Which are the main gas transport mechanisms into the lungs when you are using high frequency ventilation? Okay, this is very difficult sometimes to understand, and at least we have 6 different mechanisms that combined can induce these gas transport mechanisms. These different mechanisms are direct bulk flow from the most proximal areas of the trachea, Taylor dispersion, pendulum, asymmetric velocity profiles, cardiogenic mixing, and one, for me, the most important is molecular diffusion at the very end of the alveolus, where the alveolus is in touch with the vessel. So I think it's important to underline that even one or other mechanism involved in the gas transport mechanism during high frequency ventilation, we have to remember that the oscillatory pressure waves is going to generate what we call tidal volume of high frequency. This is the high frequency tidal volume. This tidal volume normally do not reach the alveolus, so is lower than the dead space, and for definition lower than 2.7 if the anatomical dead space is not very big. If we are using a very high tidal volume with low frequency, then the convective and some bulk flow mechanisms is going to predominate. But if we are using a very low tidal volumes at a very high frequency, this is the case of high frequency ventilation, the most important mechanism is diffusive gas transport. So also it's important to remember that the transmission of the pressure wave is completely different from conventional mechanical ventilation to high frequency. So these are the waves, pressure waves taken from the tip of the endotracheal tube. In conventional, this is in the middle of the trachea, and this is at the level of the alveolus, and you can see how the mean airway pressure and the peak expiratory pressure is transmitted quite well during conventional, but during high frequency ventilation, you can see how the pressure waves are decreased from the top of the airway until we reach the alveolus. So this is an important thing, that probably the most important mechanism that transmit gas transport here at the level of the alveolus is diffusion mechanism. And again, this is very important to remember, because as the transmission of the wave pressures is decreased as we are going longer to the end of the lung, it is completely different from the top and completely different when we reach the alveolus, then the length of the lung, the length of the airway is going to play an important role in the high frequency ventilation. This is one of the reasons why during high frequency ventilation in very premature babies, where they have these very short lungs, the transmission of the pressure is very fast and very easy. So we can use very low tidal volume, low delta P, and low mean airway pressure to handle this kind of patient. But if we have to use high frequency ventilation in bigger babies or even in adults, we will need to use higher pressure, higher delta P, and lower frequency. We are going to review how the frequency by itself modifies and transmit more or better the delta P, depending on the high or the low frequency. We will go back in a few minutes. So to ventilate a lung during high frequency ventilation, the main three mechanisms, or main 2 or 3 mechanisms for us, are convective in the proximal areas of the airway, some kind of mix of convection and diffusion at the middle, and the most important, diffusion, transmission of energy in the lower areas of the lung, where the alveolus are. So again, the transmission of the wave is related to the diameter of the airway, the branching of the airway, and the length of the lung. And is directly related to the volume during high frequency ventilation, what we call the tidal volume high frequency ventilation. And this is directly related to the delta P. This is the power of the wave. As much as higher is the power, it's going to be a higher the volume during high frequency ventilation, and we are going to ventilate more. And the other thing is the frequency. So when we decrease the frequency of the ventilator during high frequency ventilator, the displacement and the generation of power and the generation of volume is going to be higher. So the lower the frequency, the higher PCO2 removement. And these are the 2 main mechanisms for ventilation during high frequency ventilation. Probably because diffusion is the most important mechanism of gas transport, we have to remember that probably in inspiration, there is a continuous gas into the lung, and probably the gas surrounding these areas of the trachea and the bronchus is going to get out from the lung in the peripheral area. So probably during high frequency ventilation, what we have is a continuous flow in through the inner, through the middle of the airway, and a continuous gas out from the peripheral areas of this airway. So in summary, remember that alveolar ventilation is related to tidal volume and frequency. And during conventional mechanical ventilation, during physiological way of breathing, remember that the frequency and the tidal volume are the most important variables to ventilate. But during high frequency ventilation, the tidal volume is even more important, even if the tidal volume is lower than the anatomical dead space. So minimal changes in the tidal volume during high frequency ventilation are going to represent or induce bigger changes in the PCO2. So this is another important thing. High frequency ventilation sometimes, many times, and probably all the times, is more efficacious to ventilate a patient than conventional mechanical ventilation. And remember that the tidal volume during high frequency ventilation is directly related to delta P. This is the power of the pulses, the power of the movement or displacement of the valve during the ventilation. The frequency, the lower the frequency, the higher the tidal volume, and also the duration of the inspiratory time. The longer the displacement in is going to generate higher tidal volume. And you can see here, this is a wave a representation of the flow and pressure, and if we decrease the frequency, then the area of the flow is higher, so the generation of tidal volume is going to be higher. And this is the main reason why during high frequency ventilation, when we decrease frequency, we improve alveolar ventilation. So which are other mechanisms that can influence the tidal volume high frequency ventilation? Well, also airway resistance, what we were talking about, the length and the branching. So those babies with bigger lungs, or even small infants, and even adults will have more resistance to generate ventilation and to generate tidal volume. So in this kind of patient, we will need higher tidal volume during high frequency ventilation, so more powerful delta P and lower frequency. Also the compliance of the ventilator circuit and the thorax and lung mechanics. So it's important also to remember that even if we have a certain tidal volume during high frequency ventilation, if the lung or thorax mechanics change along the day, probably the PCO2 is going to be changed. So keep in mind this, because this is going to be important to the end of the talk, when we are going to review one of the important things about the handle of this kind of ventilation. And as I told you, the ratio of the inspiratory to expiratory time of the displacement of the valve, or the piston, of the membrane, is going to influence also the tidal volume. So the longer the inspiratory time, the higher the tidal volume that's going to generate. But remember that if we increase too much the inspiratory time, we have the risk of gas trapping. So this is important. How important is really to know the tidal volume during high frequency ventilation? It really means, well, I think yes. It's so important that if you have the knowledge, if you have the measurement of the tidal volume, you can see if the baby is going to be hyperventilated, hypoventilated, or normal ventilated. Let me show you. This is a very nice study from Magdalena Simova in 2006, where she connected during high frequency ventilation using a SensorMedics standard oscillator to a very premature babies, very small babies, lower than 1500 grams, and she connected a flow sensor. What she saw is that there was a very nice and clear relationship between the tidal volume that she was measuring with the flow sensor and the PCO2 at the arterial line. And even more, most of the babies who were normocapnic, they were using close to 1.7 ml per kilogram. Those babies with 1.9, this is close to 2 ml per kilogram, were hypocapnic. And those babies close to 1.5 were hypercapnic. So if we have the possibility of knowing continuously the tidal volume during high frequency ventilation, we can have a very close monitoring, probably, of the PCO2 of the babies. And this is extremely important because, as you remember, the PCO2 influence a lot brain perfusion. And one of the risks of using a very powerful ventilators is that we can decrease the brain perfusion due to hypocapnia. So monitoring of the tidal volume is going to be very essential and very important right now in the use of HFOV. So let us move to the very clinical approach. Why do we use HFOV in the newborn infant? Okay, as I told you, high frequency oscillatory ventilation can be very easy use in the neonate because the neonate has a very short and very low ramification, low branching of the lung. So the transmission of the mean airway pressure is going to be very easy. And we can improve the lung volume. We can recruit the volume of the lung easier, many times using high frequency ventilation than with conventional. And many times we can prevent the trauma of the pressure that we have to use when a baby has a very severe respiratory distress syndrome and is ventilated with a conventional mechanical ventilator. So it is very easy to use what we call the open lung strategy using lower pressure. It is simple and short airway compared to bigger infants, and we are going to need lower delta P and higher frequency compared to bigger infants and compared to adults. And this is one of the main reasons why in neonatology we use so many times high frequency ventilation in comparison with other kinds of patients. But remember, the important thing when we use this kind of ventilation is to move the lung to where I told you it is called the safety area of the lung or the therapeutic window, to keep the lung all the time open and prevent overdistation or prevent atelectasia. But how we do this during the regular day by day in the clinical practice? Okay, the best way to guide if we are opening the lung is to check oxygenation. And check oxygenation can be done by arterial PO2 or oxygen saturation. For us, it's very easy to use oxygen saturation. And the way we use this is increasing by small steps of mean airway pressure until we reach what we call the improvement in oxygenation because we open the lung. And if you are doing this in the clinical practice, it's going to be very easy to know and to guide because as we reaches the mean airway pressure that needs to open the lung, then the baby improves suddenly the oxygenation. But remember that this is a very challenging situation because we don't know really which is the time that we need to wait from any step by step increase in the mean airway pressure until the pressure opens the lung. Also remember that many times there is some inhomogeneous of the lung. You remember that slide before when we showed the rat that at certain pressure we have many alveolus open but not many others. So we really have to think about that when we are using the clinical practice. So we have different opening and closing pressure in different areas of the lung. And the stabilization time from when we apply pressure until the pressure reaches the alveolus can be as long as 25 minutes or as short as 2 minutes. And that's depend on the mechanics of the lung and the severity of the illness and the presence or no of secretion and many other things. And remember that during increasing the pressure to open the lung, the time that we need to open used to be lower than when longer than when we decrease the pressure to prevent overdistation. And one of the most important things after we open in the lung, we have to prevent damage and we have to decrease the pressure to find, as I told you, that green area the safety area of the lung. So this is the lung open strategy, and we have not many data from clinical trials or studies on how to do this, but recently we have some information about that if we are using opening pressures in a lung without surfactant, many times we will need less than 5 minutes to reach what we call the opening pressure. So probably steps of 5 minutes in those situations where the surfactant has been given should be a very good approach to wait until we have another increase in step. The other thing for using high frequency ventilation and prevent lung damage is not only to keep the lung in the safe area, but also to prevent the trauma due to the increase in delta P. So we need to use the lower delta P and the higher frequency as possible to have the best channel volume of high frequency for a target PCO2. And this is going to be ideally for each patient and from each lung situation, and also can change along the day or along the illness of the baby. So which are the initial settings for using high frequency ventilation? Let me tell you that we don't really know which one are, but probably we have to, because we are using high frequency ventilation in a baby with a closed or atelectasia or a damaged lung, we are going to need higher mean outward pressure than the mean outward pressure that we were using before during conventional mechanical ventilation. How much higher? Depends on the lung, depends on the baby, depends in many other things. The other thing is to target the PCO2 and try to find the delta P and the frequency to achieve the channel volume of high frequency ventilation that is going to be related to the PCO2. And again, remember that this depends to the size of the patient, the power of the ventilator that you are using, the disease, if there is an homogeneous or non-homogeneous disease of the lung, the presence of obstruction of the airway, and also the presence of air leak. So let us go again to the animal lab, and now let me show you in this new movie how we do these increments of the mean outward pressure using, let me show you, this is the video. And now we are using a very severe distressed lung from a piglet with a bronchoalveolar lavage, and you can see how we are ventilating the baby, or these lungs, increasing the mean outward pressure. You can see how there is no effect in the lung volume at 15. Now we are going to increase this pressure over 15, and you can see how after a few seconds there is some increase in the lung volume of the animal, and now in 20 you can see how there is some kind of recruitment, and you can see how most of the lung is recruited. If we go up to 25, then we will have even more recruitment of the lung. You can see there are some areas in the lower, the basal area of the lung that are still closed, and some areas in the front. And if you go to 30, most of the lung is going to be open. So this is a real life view of how we do what we call the open lung therapy when we are ventilating our babies. So let us move to the next slide. Well, the video was showing that increasing the mean outward pressure are going to recruit the lung, and many times what we have to do is to increase very high mean outward pressure because the lung is very damaged. So depends on the baby, depends on the situation. How much pressure are going to need depends on the situation. These are the steps that we used to need. Using the oxygen saturation, we are going to increase mean outward pressure higher than the mean outward pressure, as I told you, we were using during conventional mechanical ventilation. And we are going to increase mean outward pressure by step increasing of 2 to 5 minutes by 1 to 2 centimeters of water. Okay, this is not very strict rule, but this is the way we used to do it. We watch the patient to prevent overdosation, and after we saw this increase in the oxygen saturation, then the first thing is to decrease FiO2. We try to decrease FiO2 until 0.6 to 0.4 or 0.35 or 30 even, depends on the baby, depends on the problem of the lung. And then, because the lung is open and most of the time it's overdistended, we begin to decrease again, step by step, the mean airway pressure until we found what we call the closing pressure of the alveolus. How we recognize this? We recognize this because after decreasing the mean airway pressure, we see some kind of oxygen desaturation. So we suddenly increase the pressure again to reopen the lung, and we left the lung 2 to 3 centimeters of water higher than the closing pressure that we found. After that, we try to make an X-ray and confirm that we don't have atelectasia or overdistation, leaving the lung in some size between 6, 7, and less than 10 costal spaces. So some practical points and questions about high-frequency ventilation. If possible, we used to permit spontaneous breathing during high-frequency ventilation. We do not paralyze the babies. We try to keep the baby even breathing spontaneously, because this is the super CPAP philosophy, or the philosophy of APRV ventilation, that is, we keep the lung open and the baby can breathe spontaneously if he or she can during high-frequency ventilation. A really important thing to remember is try to do not disconnect the ventilator to the lung, because after every disconnection there is a sudden decrease in the pressure and some alveolus are going to de-recruit, and many times you will have to reopen the lung. So try to use closed system for suctioning. Even there are not many studies that have demonstrated that this is safer or not, that opening the airway, I think that it's better to prevent disconnection and prevent sudden decreases in the mean airway pressure. Remember that it's important to have a very nice and very good humidification and temperature control of the airway, and using a low compliant tubing system for this kind of ventilation. Which are the potential indications of high frequency ventilation? Well, some years ago there was a tendency, a trend of using this kind of ventilation to prevent bronchopulmonary dysplasia in very small premature babies. Because in some animal studies, they were shown that using high-frequency ventilation, the trauma to the lung was lower than using conventional mechanical ventilation. But after some randomized controlled trials comparing both ways of modes of ventilation, high frequency or conventional, there was no benefit of using high frequency. So right now, we reserve high-frequency ventilation as a rescue way for respiratory distress syndrome, most of the time to open atelectasia or open atelectasia areas of the lung. But remember, because we were saying that the high-frequency ventilation is more effective to wash out CO2, so many times it's easier to use this kind of ventilation for conditions such as the dry lung or the congenital diaphragmatic hernia, because we can use lower pressure and we can prevent damage to the lungs. And remember that if we open the lung and keep the lung open all the time, it's easier to send some kind of inhaled drug, such as inhaled nitric, to this baby. So many times it's easier to open the lung before using high frequency ventilation than conventional. Let us move to some case report just to overview this kind of ventilation. Well, this is a meconian aspiration syndrome, term baby, who came to the unit. As you can see, a very severe respiratory distress syndrome, to put it on ECMO. And well, we have here some trendings of the pH PCO2 or PO2 using an arterial inline catheter that continuously is measuring the pH, PCO2 and PO2. And you can see how the baby was on FiO2 of 100% and very severe distress. And we gave surfactant with a transitory improvement of the oxygenation. Then, because this was very transitory, we moved to high frequency ventilation, but we used a low mean airway pressure because we saw that the lung was a very inhomogeneous disease and we were afraid about having some kind of air leak. So because the effect of high frequency ventilation was not enough, we did an ultrasound of the heart and we found that there was some kind of pulmonary hypertension, so we gave inhaled nitric, and the nitric improves oxygenation until certain PO2 values and then decreases again. But this is a very transitory effect, so the baby remains in very severe respiratory distress. So what we did is we increases step by step the mean airway pressure until 25, and suddenly you can see how after reaching 25 of mean airway pressure, this baby improves very fast and very suddenly from 48 to 260 millimeters of mercury of PO2. So this is an example of how responds to the opening lung strategy of a baby with a very severe respiratory distress. This is the lung X-ray before and after high frequency ventilation, and you can see how there is some kind of overdistension of the lung. So what can we do after reaching this opening lung strategy? So what we did is to decrease FiO2. So the baby went to PO2 close to 100, and then we began to decrease the mean airway pressure from 25 step by step until 18. And you can see how when we decrease mean airway pressure, we didn't show any decrease or deteriorate the oxygenation. So we keep on decreasing mean airway pressure until 16, and we saw some kind of decrease in oxygenation. Then we reopen the lung and we leave the lung at the end at 18. And the message is, look, we have the same arterial PO2 with 18 of mean airway pressure than with 25. Remember, the lung is recute, the lung is open, the oxygenation is good without any kind of overdistension. So this is the way we used to do in the real life. This is another case report in a baby with severe respiratory distress syndrome, but now with air leak. And because there was an air leak, we moved to high frequency ventilation, and you can see here this is the trending of FiO2 100%. We moved to high frequency ventilation and we increase just a little bit mean airway pressure, and suddenly the baby improves. So we left the baby with this mean airway pressure. We decrease FiO2 step by step, and then here we decrease again mean airway pressure and we could decrease again FiO2. So this is another example of using high frequency oscillatory ventilation. And lastly, this is another example. You can see here FiO2 in a baby with a severe respiratory distress and a very homogeneous disease. And here you can see how we increase step by step mean airway pressure from here to here, and then up to here and up to here. And then we found what we call the improvement in oxygen saturation. So we left the mean airway pressure in this level and we began to decrease FiO2, as you can see here, until we left the patient with 0.6 or 0.45 FiO2, and then we decrease again mean airway pressure. So in this trending, please let me show you, because we were using the VM500 Draeger ventilator during high frequency ventilation, so we were measuring and recording tidal volume during high frequency ventilation, and you can see how we were having a very stable tidal volume during high frequency ventilation. So we did not modify tidal volume because we were just increasing and then after decreasing mean airway pressure. So this is important thing. There are two different ways, two different components during high frequency ventilation. Sometimes we have no responses or only transitory responses, or sometimes hemodynamic compromise or hypoventilation, and many times we used to say that the ventilator that doesn't work, so the baby is not doing what we want to do, but the problem is with ourselves, that we are doing some kind of errors. And the most frequent errors that we used to have during high frequency ventilation is, for example, if we don't have a response in the oxygenation, sometimes it's because we didn't increase the minimal pressure to open the lung, to open the alveolus. This is the same case as the first case report, as I told you. Or we wait too much until we step by step increase minimal pressure. Sometimes the effect is only transitory or very small, and this is many times because, okay, you decrease very fast the minimal pressure after reaching an improvement in the oxygenation. Sometimes we have hemodynamic compromise or hypoventilation, and this is, if we have this together, think about that the possibility of having overdistension of the lung is an important thing. And sometimes we do not ventilate the baby even if we are using a normal tidal volume for high frequency ventilation. And many times the problem is that the tidal volume is good, but the lung is not enough recruited. So we have to remember that if the lung is closed, even if we are using tidal volume, big tidal volume, during high frequency ventilation, we are going to have hypoventilation because the pressure is not going to be transmitted to the alveolus, to the lower part of the lung. So let me show you some new good things from the new VN500. Right now we have a very powerful ventilator. So because of this, we can transmit the energy of the delta P of the small tidal volumes even to big lungs, even to lungs with some kind of obstruction. But the most exciting thing for me is that we have the possibility of using a continuous tidal volume guarantee. So we can set a certain tidal volume and the ventilator is going to increase or decrease delta P to keep this tidal volume continuously in the same level. And this is important many times because we can prevent changes in the PCO2, arterial PCO2. So this is the schematic representation of the new VM500, and just to remember that now we have a very let me tell you, very hard, strong cerebral valve that is going to send tidal volume into the lung, and the transmission of the pressure is going to be now very, very, very nice. So we can ventilate patient over 3 kilograms of weight and even up to 4 to 5. And now the ventilatory effect in the expiratory limb is very strong. So now the transmission is much better than the old Babylog 8000 Plus. But the most exciting thing is the possibility of using volume guarantee during high frequency ventilation. Remember that the volume guarantee is a modality of setting volume, expiratory volume, tidal volume, by increasing or decreasing the peak expiratory pressure during conventional mechanical ventilation. So this modality that was patented by Drager now can be used during high frequency ventilation. So what we do is we try to find the tidal volume of high frequency ventilation that target the PCO2 that we want. And then we set in the volume guarantee modality, and the ventilator is going to increase or decrease delta P to keep the tidal volume in a constant way. So let us move to this video, and then I'm going to show you how when we decrease in this test lung the compliance, this is the flow, this is the pressure, and we are going to decrease the compliance of the test. There is an increase in the pressure of delta P, you can see here, just to compensate the decrease in the tidal volume. So this is the way the ventilator works. Going to the animal lab, and what we did here is to connect to a newborn piglet, a ventilator, a VM500 during high frequency ventilation, and we just found that using 8.2 ml as a total of tidal volume during high frequency ventilation with delta P of 25, the arterial PCO2 was in the normal range. So just to demonstrate that any change in delta P is going to be transmitted with a change in tidal volume during high frequency ventilation, you can see how after increasing to 30, the tidal volume increases to 9.4. So small increases in delta P is going to be transmitted as small increases also in delta P. So we can use this delta P to try to set and find which is the target PCO2 that we want. And then we went down again to 25, and again you can see how again we are in 8.2. So what we did now is to set the ventilator in the volume guarantee modality, and we set in 8.2, and now we are doing nothing, and the ventilator is going to increase or decrease delta P to keep constant 8.2. So what we did now, we did a bronchial lavage to the lung. We induce a very severe respiratory distress that changes the lungs mechanics very fast. At the very beginning, there is a decrease in the compliance, and after a few minutes, there is an improvement. Let me show you what happens when we were using volume guarantee. This is the moment where we did the bronchoalveolar lavage, and you can see how the ventilator was keeping 8.2, 8.1, and increases spontaneously to 32, then to 33. Here you have the tidal volume constant and the increase by the ventilator to 33. And then because the lung improves after a few minutes, there was a trend in decreasing delta P to keep all the time constant 8.2. So let us go to the clinical practice. This is a baby, newborn baby with a severe respiratory distress syndrome, ventilated by the VM500. And now you can see this is the trending of delta P along the time, and this is the trending of the tidal volume of high frequency ventilation. And the baby was with high frequency volume guarantee. And you can see how along the time there was an increases and decreases in delta P because the ventilator was trying to keep constant tidal volume, and you can see how constant is this trending even if the ventilator is increasing or even decreasing delta P. Let me show you another example. This baby was with high frequency ventilation and with volume guarantee, and this is the tidal volume trending during high frequency ventilation, so continuously stable in this level. And then at the level of the red arrow, we switch off the volume guarantee and we leave the ventilator with settings of the delta P. And now you can see how changes tidal volume along the time depending on the lung characteristics of the baby and the thorax or the movements or many other things. So you have here a decrease in the tidal volume and a tremendous increase in the tidal volume here, and along the time a progressive decrease in the trending of the tidal volume. So probably we have to have more data from clinical trials. This way of ventilation is going to prevent this kind of changes along the time. So we are going to finish right now, and I would like to summarize in only one slide all this lecture and to give to you some message. Remember that high frequency oscillatory ventilation from a neonatal point of view is a rescue therapy. And because it's a rescue therapy, we try to use it to protect the lung when we need to use a very high settings during conventional mechanical ventilation in a baby, because there are some evidence that using high frequency ventilation can be lung protective in many situations where you have a very severe respiratory distress. It is easier to recruit and to open the lung when you have a closed lung or the presence of atelectasia. It is very effective washing out CO2. So in some situations where you have a small lung, such as the dry lung, congenital diaphragmatic hernia, or many other situations, you can use this easier to remove CO2 than with conventional mechanical ventilation. Again, it is very important to remember that the ventilation is correlated to the tidal volume of high-frequency ventilation, and you have the possibility of measuring it continuously, then you probably will be in a safer way of using the high-frequency ventilation, preventing sudden increase or decreases in the CO2. And probably we need some more evidence about this, but probably using the volume guarantee during high frequency ventilation should be a safer way to use high frequency. But remember that high frequency ventilation will only attenuate the ventilation-induced lung injury if we combine with an optimal lung volume, or what we call the open lung strategy. So thanks so much for joining us to this webinar, and now I think we are open for comments, questions to answer to you. Thank you. Okay, let us try to answer your questions. Thanks so much for giving us this feedback. Well, the first question is coming from Naline. Should we paralyze the baby during high frequency ventilation? Okay, we try to do not. We try to do not. If you paralyze, sometimes you need to increase even more mean over pressure or not. We have seen that normally a baby breathing spontaneously, even if the baby is big, do not interfere with the high frequency mechanism of gas exchange. Remember that during high frequency ventilation, what we need is to have the open lung strategy and then try to diffuse the gas molecules at the end of the airways, at the level of the alveolus. So normally when the baby tries to breathe spontaneously, even if he is doing some kind of tidal ventilation, do not interfere with the ventilator. So we try to do not paralyze the babies. So another question is Stefano. Thank you for your feedback. It's nice to hear you enjoy the presentation. What do you think about using DCO2 to elevate CO2 lavage? Is it an effective parameter? Oh, yes, it is. But remember that this is only a mathematical formula. If you do not modify frequency, the only parameter that really influences PCO2 is the tidal volume. So remember that the DCO2 was a parameter that multiplies the frequency in hertz to the tidal volume. So for me, the most important mechanism to control CO2 lavage is to use the tidal volume. So tidal volume during high frequency ventilation can be modified in two ways. As you know, increasing or decreasing delta P, you will have small increases or decreases in tidal volume. But if you want to increase a lot or decrease a lot very fast the tidal volume during high frequency ventilation, then you have to modify the frequency. So if you are only trying to set the ventilator to keep the baby within normal PCO2, at the beginning sometimes you need to modify very fast the frequency, but at the end, when you find a very close PCO2 level close to the target PCO2, then the only thing you have to do is to increase or decrease delta P. And if you leave the ventilator alone with the volume guarantee modality, then the ventilator is going to increase or decrease delta P by itself. So I think the best way to handle the PCO2 is just to monitorize the tidal volume more than the DCO2. So CQ groups, hello, you're good friends. We have been together a few days ago. And the question is, hello, what are your recommended frequency now with the extreme preterm infant? Oh, this is a very nice question. Well, I think we have to remember that depends on the ventilator you are using. If you are using a very power ventilator, remember that, and you don't have the tidal volume information, then try to use the highest frequency that you have. So for babies below 700 grams or close to 500 grams, we used to recommend to use the highest frequency as possible, close to 15. But now, because we have the possibility of knowing how much tidal volume during high frequency ventilation we are sending, what we try to use is the combination of the highest frequency and the lowest delta P. So in the most tiny baby, we began to use higher than 10 with the VM500, close to 12 or close to 15, and then we take a look about the tidal volume that is generated in the ventilator, and we try to adjust the delta P to the lowest, close to 20 or 25, and then we set in the volume guarantee modality when we found the PCO2 that we need. So the highest frequency that you can. So Cosma's question is, my question is whether you use higher frequency with a smaller baby. I think this is the same question. Yes. Remember that if you want to transmit more energy to the alveolus, you will have to decrease the frequency. There is a trick to remember this, okay? Remember that the frequency of a ventilator during high frequency ventilator, what is generating is energy. And the energy generated by the ventilator is very similar to the energy of a speaker, the energy of the sound. So the lower the frequency, the better transmission of the energy. So when you use lower frequency, the transmission of the energy to the molecules that are very close to the alveolus are very effective. So decreasing the frequency, you are going to move a lot of gas molecules into the lung. So try to use the lower transmission of energy. So increasing the frequency, you're going to decrease the risk of a very high tidal volume displacement. So again, remember, the lower the frequency, the higher the volume that you are going to move. So quantitative question, when you're using volume guarantee with HFOV, what tidal volume would you start with? Still 6-M. Okay, now remember that when we are using high frequency ventilation, by definition, the tidal volume that we are using is lower than the anatomical dead space. And this dead space is 2.7 if you're having a normal lung. So anytime you use high frequency ventilation, you have to hide away from too high tidal volume. So below 2.7 all the time at the beginning, and then try to set the lowest to prevent damage. As you saw the study from Madalena Simova in 2006, those babies close to 1.6 or 1.7 were normal ventilated. So 1.6, 1.7 per kilogram in the premature baby should be a good initial point for starting the ventilator. And in the term baby, probably you will need to be closer to the 2.7. So in those term babies with a very severe respiratory distress, with a very high PCO2, then we try to move closer to 2.2, 2.5, or even 2.7 ml per kilogram. But this is the highest at the beginning. So question for Custer, what is the range of inspiratory time you have experience with? Thanks. Okay, well, this is a very challenging question. Oh my God. Remember that many times what we used to use is a lower inspiratory time than expiratory time. So the ratio normally is lower than 1:1. But remember that sometimes if you are using a very short inspiratory time, then the pressure generated by the ventilator is not reaching to the alveolar area. So if you want to increase the efficacy of ventilation, then sometimes it is better to increase the inspiratory time and go to closer to 1:1 more than increasing delta P. So normally we try to use 1:3, 1:2 at the beginning, and the smaller the baby, the lower the inspiratory time. But if you have a very severe respiratory distress syndrome with a very severe disease in the lung, probably an obstruction of the lung, then you will have to move closer to 1:2 or even 1:1.5 or 1:1. And another question is, what is your preferred IE ratio? Okay, we have been talking about that. Alerta is asking, do you extubate the baby to CPAP directly from? Yes, we try. Sometimes you can't. because the baby is not training in breathing spontaneously. But we try many times. You move to conventional when you reach 7 or 5 minute repression in the ventilator, but you can extubate the baby directly to CPAP, and if you want, you can try. There is a question in Spanish that is asking which should be the way if we use volume guarantee. Do we have to take out the volume guarantee if the volume is if delta P is too high? Okay, well, the question in English is that if we are setting a certain tidal volume and then the ventilator goes very up in delta P, then the best way is decrease the frequency. That is it. So remember that the ventilator right now is only going to modify delta P. The ventilator is not going to modify the frequency. So you have to be careful about that. If the ventilator is decreasing very fast delta P because the baby is improving, probably this is very good news for the baby. But if the ventilator is increasing too fast to a very high level of delta P, then sometimes it's better to decrease the frequency to prevent a trauma with the pressure with a very high delta P. So again, sick kids, what are your recommendations regarding air trapping, illness, like pulmonary interstitial emphysema, with regards to minor repression and frequency? Good question, good point. Oh my God. So probably you have to individualize the babies. So what we try to do when we have this kind of very severe respiratory distress with gas trapping and pulmonary interstitial emphysema, where we try to use the lower pressure as possible. The lower pressure to prevent even more gas trapping. But those babies, we move very fast from conventional to high frequency ventilation. And we use the lower minimal pressure as possible. And then we try to transmit with a very good delta P the best tidal volume. So we use the lower minimal pressure, and sometimes we go to low frequencies to increase tidal volume. We have some more tricks, but probably we can discuss together about this kind of handle of the interstitial emphysema, such as using sometimes, for example, helium, but this is another history. So, Doug, is there a best way to determine the gas flow rate in the 3100? Oh, yes, could be, but probably the best way is to set at the very beginning and to follow, the factory indication. That you have to set at the very beginning which is the occlusion of the system, the compliance of the device before using it, and then we used to begin 20 or 25 for the very small babies, or close to 30 to those bigger babies, or even 30, 35 if we need more pressure. But the flow is going to be directly related to the delta P that is going to generate volume during tidal ventilation, during high frequency ventilation. So if we need higher volume, higher tidal volume during high frequency ventilation, then we increase the flow of the sensor. So Thomas is asking what delta P you recommend to start with small premature babies. Okay, we try to use lower than 20, 25 if we can. But again, if you have the possibility of knowing how much tidal volume you are using, then this is the best. This is the best way, because we try to use in these very small babies, very premature babies, higher than 1. Sometimes very premature babies, lower than 700 grams, we can ventilate them with lower than 1 ml per kilogram. And this is very, very, very fine, because we can decrease delta P even to 15 centimeters of water. So try to know how much volume you are setting, and then decrease as much as possible delta P. So in the very preemie babies, we try to use the lower as possible, and we begin to 20-25. And another question is with the new baby lock. That is, yes, we use the new baby lock, yes. And let me ask if there is any other. This is I think we have only one more. Do you use sang breath during high frequency ventilation? Not now. You know, in the late 80s, there were some trials, some studies coming from the United States that they recommend, and coming also from the north of Europe, that they recommended to use a combination of tidal ventilation and high frequency at the same time. But we try to do not use right now any kind of these things, because the sang is to prevent closing of the alveolus, to prevent the recruitment, but also can induce some kind of overdistation. So because we are not seeing the lung all the time continuously, so we do prefer to test every day or every 12 hours, for example, which is the opening and closing pressure of the lung, and then leave the lung alone without any kind of signs. We don't use it. We don't use it. So I think we are on time.